to share our experience and knowledge with the rest of the group through the World Institute of Critical Care and Emergency Medicine. For the sake of time, I'm going to be very direct. And the outline of my talk is going to be with few definitions and goals of mechanical ventilation, elaborate more on heterogeneity, and then briefly mention the guidelines before we go into individualized mechanical ventilation care. And if I want to define ARDS, I would say it is a syndrome, not a disease. And it is characterized by inflammation, increased vascular permeability that leads to increased lung water, that will lead to consolidation and stiff lung, that will decrease the functional lung volume. That's why we call it baby lung. And of course, it's going to impair gas exchanges. And thank you, Pedro, for the showing that the definitions have changed. And there are challenges. And that is actually because of the heterogeneity of the disease. So let's start with this poll. Please scan the barcode and answer the question. In ARDS, what are the primary goals of mechanical ventilation? You can enter up to 4 words, and you can enter 1 word only. So scan it on your phone and contribute to this poll, please. So you need to type your response. Excellent. We have some saying PEEP, lung protection, oxygenation, lung safety, keep the alveoli open, address hypoxia, low tidal volume, and rest the lung. I'm going to move forward and state that it is really important to understand the difference between stress and strain. Stress is the pressure applied on the area, and that is going to result into strain, which is deformation. This is how individuals are going to accommodate to a stress. On the ventilator, stress is transpulmonary pressure, and strain is the change of volume and the shape of the alveoli. And you can see that clearly here. On the left, you will see a huge strain compared to minimal strain on the right side. You can see the change in the diameter of the alveoli on the left side compared to the right side. And goals of mechanical ventilation can actually be now broadened into not only protecting the lungs, preventing iatrogenic injury, decreasing ventilator-induced lung injury, but also protecting the diaphragm. And we need to make sure that the diaphragm is not going to be injured because of our mechanical ventilation. It is also aimed to preserve hemodynamics. You want to make sure that the venous return is not decreased and causing hypotension. And also, your ventilator settings are not affecting the right heart and causing right heart failure. Of course, you're aiming to improve gas exchanges, and you want to minimize the effects of hypoxemia and hypoxia on the tissue. At the same time, you want to prevent oxygen toxicity, and they put a question mark about that because there are conflicting literature in that regard. And the last thing is you need to relieve the excessive workload of breathing that will lead to self-induced lung injury, or what we call SILI, and at the same time diaphragmatic injury that needs to be minimized. I can summarize the protection of the lungs, diaphragm, and right heart on this slide, and you can detail more on every single item within this slide. The next poll question: what is the most common phrase in any ARDS talk? Please scan the barcode if you did not already. This is question number 2, and let's see what is the most common phrase in any ARDS talk. And already Pedro mentioned multiple words. It is heterogeneous, we need more RCTs, follow the guidelines, and there is no right and wrong answer, by the way, or it depends. So we see 60% saying it is heterogeneous, and 27% would say it depends. And that is actually what we mean by heterogeneity. And let's just scan this again and contribute to this poll. Start putting the answers, please. It's going to be similar to the first one. Right? So what are the identifiable subphenotypes of ARDS? So pulmonary versus extrapulmonary. All right, so I don't see that we're getting the answers we need, so let's go through them. So number 1, we have spatial heterogeneity. Within the same patient, you have different areas. Some areas are collapsed, other areas are consolidated, and other areas are normal. And each one has a different PV curve. What you see on the ventilator is the global PV loop. So that's why we do not know how much of the lungs is normally ventilated, how much is collapsed, and how much is consolidated. And then we have etiological diversity or heterogeneity. We know that some cases are caused by pulmonary etiology, such as viral pneumonia, aspiration pneumonia, bacterial pneumonia. This behaves different than if it is extrapulmonary, caused by sepsis, pancreatitis, extensive burn, hemorrhage, or intra-abdominal hypertension. The cases that are pulmonary caused have higher lung compliance and likely to have focal pattern, compared to lower lung compliance, higher pleural pressure, more diffuse, and higher biomarkers in extrapulmonary. And they have variable responses to PEEP and proning. Pulmonary etiology responds more to proning compared to extrapulmonary responding to PEEP more. And then we have physiological heterogeneity. We know that the effect of ARDS vary from one patient to another depending on the extent and location of lung injury and multiple other genetic variables. The gas exchange, the lung compliance, the ventilatory impairments are actually different. We can differentiate between recruitable subphenotype, where we have more dead space, more non-inflated areas, lower compliance of the respiratory system, lower PF ratio, and they have higher risk of death, and they benefit more from higher PEEP compared to a non-recruitable pattern. In this study, it shows also that we have biological heterogeneity. And this is based on the ARMA and the alveoli trials. They actually subclassified ARDS into two subphenotypes. Phenotype 2 has higher plasma concentration of inflammatory biomarkers, lower serum bicarbonate, higher prevalence of vasopressor use, and higher prevalence of sepsis, poor oxygenation. They benefit more from higher PEEP compared to subphenotype 1, which is hypoinflammatory, lower plasma concentration of biomarkers, better oxygenation. This form of this subphenotype benefits from lower PEEP. And this is the data that showed that mortality, ventilator-free days, and organ failure-free days are actually different between phenotype 1 and phenotype 2. If we want to continue on the biological heterogeneity, we can identify that we have biomarkers released from the epithelial injury, mainly what we call RAGE, receptors for advanced glycation end products, compared to injury on the vasculature or vascular inflammation, which is represented essentially by the angiopoietin 2. And this way we can classify cases where they have vascular inflammation mainly, compared to alveolar inflammation mainly, but most of the cases they start in one direction and goes to the other direction. You have combined inflammation. If you have a high RAGE or receptors for advanced glycation end products, you will see it more in direct injuries compared to indirect injuries. So this is the pulmonary ARDS. Compared to higher angiopoietin 2 in indirect injury or the extrapulmonary ARDS. And you can see that those patients who had higher level of angiopoietin 2 had higher mortality compared to the other group. And as per the previous presentation, you see the difference between diffuse ARDS and focal ARDS. And they respond differently to different modalities of therapy. The focal ARDS responds better to prone position. Diffuse ARDS responds well to alveolar recruitment strategy. In this study, they looked at the different percentages of those focal versus diffuse ARDS cases. Also, you can look at temporal heterogeneity, meaning that cases of ARDS that develop within the first 24 hours or 48 hours of ICU admission compared to ARDS that develops after 48 hours. They have a longer ICU and hospital stays in addition to higher mortality and higher scores of SAPS. And they can see here that mortality is higher, mechanical ventilation days are higher, and ICU stay days are higher in the late onset ARDS compared to the early onset ARDS within the first 48 hours of ICU admission. And you all know about the temporal heterogeneity in terms of different phases of ARDS. The ARDS goes from exudative to proliferative and then fibrotic phase, and patients in the exudative phase respond better to proning and PEEP. So we can actually classify ARDS based on the heterogeneity and the diversity, whether it is physiological, biological, morphological, or clinical, based on what we just described. And what we're trying to do is we're trying to treat ARDS with the same modalities for all those patients. And it doesn't work. When we set guidelines, and that's why the guidelines are changing and they are contradicting from one country to another because it's heterogeneous syndrome. So let's just answer this. Managing ARDS feels most like following the book, you're following the guidelines, shooting in the dark, you don't know what you're doing, compared to a roller coaster, or the last one is solving a puzzle. Let's get more votes, please. I'm not seeing contributions, so let me move forward. So many clinical trials that treated patients with ARDS as unified group have failed. Different results with same modalities of treatment, same modality of treatment. We get different results depending on the population that we're treating. And from the start of the most cited study in the critical care literature, the ARMA trial that showed decreased mortality from 40% down to 31% if we just use lower tidal volume and lower pressure. And then we learned that the driving pressure is actually important, and initially we wanted to keep that driving pressure below 15, and we defined protective lung strategy as number one, tidal volume should be 4 to 6 ml per kg of ideal body weight. Number two, we need to avoid high plateau pressure and keeping the plateau pressure less than 30. Number three, we need to shoot for lower driving pressure, and the lower driving pressure, the better mortality. Initially, it was defined to be at 15, and now we're shooting for lower range of driving pressure, and you will see the different studies next. And the last thing is we need to use appropriate PEEP for the patient. And this is actually a very nice study summarizing the different modalities based on the severity of ARDS and where do we use each of these modalities. But I want actually to call your attention that the difficulty is actually we're dealing with dual pump system. We have the ventilator for one side, so when we set our ventilator settings, we need to avoid the ventilator-induced lung injury. But at the same time, the patient is breathing on the other side, and he's actually driving the air in with his intrathoracic pressure. And that is going to cause patient self-inflicted lung injury. And when we apply the equation of motion that you see it at the bottom here, you really need to consider the muscular pressure or the intrathoracic pressure that is generated by the patient. And that's why we're talking about individualization. And when we say individualization, let's see what we mean by, do you use driving pressure to guide your ventilation? Yes, routinely, sometimes in select patients. I know about it, but I don't use it, not at all. Let's see better contribution, please. Yes, routinely. We have 5 votes, 7 votes. I know about it, but don't use it in 12%. Sometimes in select patients, we have 20 votes, 21 votes. So 72% voted that they use it routinely, which is great. But let me actually present the equation of motion to you this way. I removed the dynamic part of the equation. So what I have on the left side is the pressure. And we really need to include the pleural pressure in the formula. That's why I subtracted the normal pleural pressure from the plateau pressure. And then we have the PEEP in the system, so I subtracted these two pressures from, of course, the pleural pressure could be negative or positive, depending on the case. Minus PEEP will equal tidal volume divided by the compliance. So the first thing is we can actually personalize the tidal volume. And number two, we can individualize the pressure for the patient. Number three, the PEEP. And number four, the transpulmonary pressure. Let's just take them one by one. Personalized tidal volume. So we aim for 6 ml per kg. Is this the right thing to do for all patients, or should we actually look at other parameters? In this study, and this is actually in rats, when they looked at the healthy lung here compared to the diseased lung, and they applied 6 ml per kg, and this is what we do, and you will see that in a healthy lung, you'll be able to expand this alveoli very nicely. So they're all going to be affected the same. However, if you take this part here, where you're including different parts of the lungs, and you apply 6 ml per kg, you're going to affect the alveoli in a different way. You're going to expand those healthy alveoli. However, you have alveoli that are diseased, collapsed, or consolidated that may not be actually open at all. And this is what is causing the atelectrotrauma if we open and close, or the polytrauma that will probably end in barotrauma. And in this nice study that was done in rat, it showed that what we see on the ventilator at the macro level may not actually be the same at the alveolar level. And you can see here comparing APRV to CMV, where we're using larger tidal volume in APRV than what we see at the macro level compared to CMV. However, at the micro level, at the alveolar level, what we see is the same tidal volume. So double the lung tidal volume in APRC, yet the same alveolar tidal volume in both modes. So actually, the tidal volume that we set on the ventilator reflects the total lung size based on the predicted body weight. And it will not consider the extent of aeration loss that we have in a single lung. And this is actually going to be very variable from one patient to another patient. In other words, the tidal volume of 6 ml may still be high and injurious in some patients, and those patients would be at risk of hyperinflation even if the tidal volume is limited to 6 ml per kg. So better if we actually look at the driving pressure, and that's what Pedro was emphasizing actually, that we need to link the tidal volume to the driving pressure. And in this study actually, they showed that the driving pressure of 15 or lower is associated with lower mortality. And you can see the mortality continues to go lower in patients with lower driving pressure. And Pedro actually just presented very nice study showing that the age of the patient is going to be dictating the outcome based on that driving pressure. So I would say let's target the driving pressure, and let's target less than 14, better less than 11 or less than 12 at least. It's of course going to be difficult in patients with high compliance, because that driving pressure is not going to be able to drive the air, and you're going to have some issues in terms of the hypoventilation. But in the general rule is let's use the driving pressure to decide about the tidal volume that we use. The next thing is, what about the pleural pressure? Actually, we only look at the driving pressure, but we do not account for the pleural pressure. And let's just think about extrapulmonary ARDS compared to pulmonary ARDS. You need to push that diaphragm actually. The pressure in extrapulmonary ARDS is on the lung, is not within the lung. And now we have the pleural pressure here and the plateau pressure. So plateau pressure minus pleural pressure. If the pleural pressure is negative, at that time it's going to be huge transpulmonary pressure. If it is positive, it's going to be limited. So this is actually dependent on the compliance of the lung. Is it compliance of the chest wall or compliance of the lung? And you can see here that in pulmonary ARDS, the chest wall compliance is normal. In extrapulmonary ARDS, the chest wall compliance is elevated. And you can see here that those patients with extrapulmonary ARDS benefited from PEEP much better compared to ARDS caused by pulmonary causes. And to explain this more, let's take a look on the transpulmonary. What do you mean by transpulmonary pressure? Is the difference between the airway pressure or the alveolar pressure minus the pleural pressure. And this is very important in extrapulmonary ARDS, where you have an increased pleural pressure. You need to measure the intrathoracic pressure in those patients. Let's take these 3 examples here, and let's see how the transpulmonary pressure is going to be different. If I have alveolar pressure that you see on the ventilator of 30 centimeter in the first case here, and you have a pleural pressure of 0, your transpulmonary pressure is 30. For the same patient that you see alveolar pressure of 30, if the intrathoracic pressure is minus 15, patient is exerting huge inspiratory effort, your transpulmonary pressure is going to be 45. And now when you talk about neuromuscular blockade, well, when you use neuromuscular blockade for those patients who have transpulmonary pressure of 45, is going to benefit those patients. Compared to alveolar pressure of 30 centimeter in a patient who has extra pulmonary ARDS caused by increased abdominal pressure and the pleural pressure is plus 15. What is a transpulmonary pressure? Is 15. And you can see the difference in these three conditions. And of course, this is studied in one of the major studies, the EPVent-2 trial, that looked at the effect of esophageal pressure, guided positive and expiratory pressure on survival in patients with ARDS. And the study found out that when you are dealing with low Apache 2, meaning low severity of illness, this modality actually helped and showed that it's going to improve outcome. And you see here the p-value is 0.03 compared to high Apache score. Patients who are sicker, this modality did not show statistical significance. But in any way, if you target transpulmonary pressure in all patients around 0 plus minus 2, at that time you will see that there is actually improved mortality in those patients where you're keeping the transpulmonary pressure 0 to 2. And this is actually more signified in another study that shows the driving pressure of less than 15 on the right side here. You see a difference in mortality. And when you look at your obesity patients, you will see that the transpulmonary pressure that is kept above 0 is associated with higher mortality in obese patients compared to non-obese patients. And I can show you here one example, what also the effect of intrathoracic pressure. You can see this is a real patient who's placed on 280 of tidal volume. And this is the mode is ABVCMV mode, which is PRVC, pressure regulated volume control. If the patient started to breathe, he's actually going to pull in more tidal volume than what you're aiming for. And this is actually where you would say neuromuscular blockade is going to be of help, or the measurement of esophageal pressure is going to be beneficial to you in a way that you can adjust your modality of therapy for those patients. And this is actually an example of the patient in the middle here, where this patient would have a high transpulmonary pressure injuring the lung, and this is how transpulmonary pressure is going to be represented dependent on whether you're putting the patient on volume assisted control versus pressure assisted control. Any inspiratory effort in patients with pressure assisted control mode of ventilation is going to be added to that pressure that you have on the ventilator, and that is very injurious. So what we would be able to say, well, now why don't we shoot for tidal volume determined by the transpulmonary pressure rather than driving pressure? But of course you need an esophageal probe in order to do this. And this is an example of a patient that we had in our ICU where we had the esophageal probe in, and you can see the plateau pressure here is at 27. The pleural pressure is, or the esophageal pressure is 20.7. And the transpulmonary pressure is actually at 7, which we thought it would be very safe for the patient. And you can see that we used PEEP of 18 in order to get to this level. And then we need to look at the PEEP and try to personalize PEEP for those patients. Now, what the problem with PEEP is, if you actually put it in patients who is very compliant, you're going to expand the areas of the lungs that are normal. And that's going to cause expansion or valley trauma. And you're going to be, if the PEEP is not set at an appropriate level, you're going to cause cycling, opening, and closing injury that is going to be giving you atelectasis. Now, multiple studies have actually looked at whether we should use low versus high, and you know that those individual studies did not actually show results that are going to favor one modality compared to other, except in certain population. And when they put all those studies together in a meta-analysis, they found out that PEEP, higher PEEP without recruitment maneuver, as presented by the previous talk, is actually associated with probably better mortality at rate of 99%. So when we look at the PEEP, how we're going to set it differently in different patients? Well, the first thing is actually, why don't we look at the pleural pressure and set the PEEP in a way that is going to give us transpulmonary pleural pressure in expiration around 0. And this is the same patient that I just presented. This is before we adjusted the PEEP level. And you can see here that we had, this is end expiration now. We have the level of PEEP is 12. We have the pleural pressure here, esophageal pressure in expiration at 15. And you can see that transpulmonary pressure in expiration was -3. And we wanted to aim for transpulmonary pressure more than 0. So what we did is, or around 0, we increased the PEEP gradually, and it was up to 18 centimeters of water. And at that time, we got a PEEP of 18 here, esophageal pressure of 17, and the transpulmonary pressure during expiration is 1.6. So that's the first individualization of PEEP. The second thing is actually how the PEEP is going to affect your compliance. You want the adequate PEEP, you want to recruit the lung, but you do not want to cause over distension of the normal alveoli. So the PEEP level that is desired is the PEEP level at which both over distension and atelectasis are minimized. And in this study, the subphenotypes that looked at the, I just presented this study, but this is only the alveoli cohort only. The previous slide was about both the ARMA and the alveoli. And you can see the different effect and different outcome of low versus high PEEP in phenotype 1 compared to phenotype 2. So the PEEP can actually be good if you're going to recruit the lung, but at the same time, you do not cause over distension, which is not good for the patient. How can we differentiate this? How can we decide what is the PEEP level that is not going to cause over distension? So with the current way we're practicing, there's no way I would know if the PEEP is going to cause more distension in certain areas of the alveoli compared to recruitment. And if the ideal way is actually to do CT scan. We're learning more about using ultrasound in determining recruitment and making sure that we do not over distend. But it's actually variable experience, and we don't have enough studies actually to guide us on how we can utilize this in the best way. And you need a lot of training for those physicians in the ICU. There's something that has been described. It is nice, we do not do it routinely unless you have a special type of ventilator, which is the EIT, electrical impedance tomography. And what we mean by that, actually, you have 2 electrodes and you just give a current. And that current is actually going to be impeded dependent on how much air do you have. You know that air does not transmit electricity. So if we have a overexpanded areas in the lungs, is going to impede the transmission of electricity, and then you can actually get a visual representation of the lungs based on how much does the lung impedes this electrical activity. There are multiple, I'm not going to detail much actually in how we do this, but you can see that there are 16 versus 32 electrodes, and current is going to be given by 2 electrodes, is going to be received by the remaining electrodes, and then it rotates around, and this is how you get the image. And you can see here is actually put in the mid-chest area, and then you get computed tomographic axial image of the thorax. This is with 32 electrode belts, and then you look at the functional image reconstructed. Now, white means air, and black means no impedance at all. So here actually, if you see white, it's not good. Actually, in the next one it looks better. You have two different color coding. The Drager ventilator company uses this color coding: black for no impedance change, blue for intermediate, and that's what you need to see, and then white for the strongest impedance change, meaning that there's too much air here. It could be a different coding: red for the highest relative impedance, this is air, green is medium, and blue is lowest relative impedance. And we say relative because it's actually compared to a control images when it's taken initially. And you can see it actually dynamically. You can see here this patient that this area is not actually represented by any bluish coloration. This is not aerated compared to this area that is aerated acceptably. In the middle here, you can see that there is expansion, more aeration in that area. And you can see that this is the same patient. This is the CT scan. This area is black here because there is no ventilation at all in this area. This is ventilated adequately. This area is expanded. It's like there is increased aeration in this area in the middle part here. Not only that, you can do also the you can do the decremental positive end expiratory pressure maneuver, where you can actually decrease the PEEP from 24 all the way down to 4, and you will be able to determine what is the ratio of areas of the lungs that are hyperventilated compared to areas of the lung that are collapsed. And you can look at the compliance. And notice here that the area of highest compliance is not necessarily the area that is giving you the minimum amount of hyperventilated and collapsed areas. So here the PEEP should be set at around 14, compared if you're following the compliance is going to be at 16, and we don't want to do this. I'm not going to explain this, but it gets in more details actually, and this is also detailed explanation of the same procedure. So we reached to the fact that, well, we need to identify those patients who are going to be benefiting from also proning. Are we going to personalize proning or not? So, well, of course, distribution or redistribution of tidal volume towards the dorsal areas is going to be different between focal versus diffuse ARDS. It is favored more in patients with focal ARDS, and you can see here in those patients with focal ARDS, you can see how you can redistribute to the ventral areas, and you can use the same modality also to determine whether you benefited from proning or not. So, and you can see the impedance here, the compliance. You can see the first patient is having compliance gain, meaning that he benefited from proning, compared to the second patient here, no improvement in the compliance or no benefit from proning. This is the study that presented by Pedro, the live study. So it was nicely presented. I'm just going to quickly go over it. There is a difference in mortality only if you look at those patients who had the modalities per protocol. And as he mentioned, 20 to 21%, I believe, were misclassified. And if you see that when we misclassify our patients and use the personalized modality for those patients, we're having a difference in mortality. So it is very important to identify the right patients for the right modalities, so we don't cause this any difference in bad outcome. And the last thing that I'm going to go quickly on is the muscular pressure of the diaphragm and the respiratory muscle. We have the respiratory drive, the phrenic nerve, and the diaphragmatic functions. We need to understand how much efforts the patient is doing by, number one, assessing the respiratory center by occlusion test. Number two, electrical activity of the diaphragm. Number three, diaphragmatic activation by the ultrasound. Number four, esophageal and gastric pressures that will determine esophageal pressure time products. And lastly, inspiratory and expiratory occlusion pressures. The pressure in the first 100 milliseconds will give you an idea about the central drive. If you have a patient with increased or decreased P 0.1, which is less than minus 3.5, the normal is between minus 1.5 to minus 3.5 centimeter. If you have numbers less than minus 3.5, this is under assistance of mechanical ventilation. But on the other side, you may be given over assistance if that number is more than minus 1.5, meaning that minus 1 or 0. And the next thing is actually diaphragmatic activity. If you have a probe in the esophagus, in NAVA mode of ventilation, you'll be able to assess that electrical activity of the diaphragm and make sure that it is within the target that you need, between 10 to 20 microvolts. You can see here a patient with electrical activity of 5.5 and another patient here 17 microvolt, which is very appropriate. You can look at the diaphragm by the ultrasound and you can assess the excursion of that diaphragm. I want to show you, this is a patient that I did myself actually. You can see here he's on pressure support ventilation and you can see how much he's contracting the diaphragm. The excursion for this patient was 7 centimeter. Anything that less than 1 centimeter is actually mini weakness. Anything more than 3 to 4 centimeter, that is huge activity of the diaphragm. And in terms of esophageal pressure time products, if you have esophageal monitor, you can look at the drop in the pressure and you can determine the target that should be minus 5 to minus 12, so you can preserve some functions of the respiratory muscles. And if you're looking at the time pressure product, it should be between 50 and 200 microvolts, and this is just to delineate the different components of the decrease in the pressure when you take an inspiration or when the patient takes an inspiration. If you multiply the pressure by the volume, you get work of breathing, and that should be between 0.2 to 0.9 joules per liter. And the last thing is the occlusion pressure. You can actually occlude the circuit, whether in inspiration, expiration, see if the patient takes any inspiratory efforts, and measure that occlusion pressure. 2/3 of the pressure will give you the esophageal pressure if you don't have esophageal monitor. And this is just to show you on our ventilator. This is the PEEP, and this is auto PEEP, of course. Occlusion here. Look at the patient. He took inspiratory efforts, dropped the pressure from 8 to minus 7.7. That is a difference of 15.7 centimeter. 2/3 of that would indicate what his esophageal pressure. Those are the targets that we aim for in different modalities of measurement, and this is the summary of my presentation. I tried to cut it shorter because of the time constraint. I know that we've been here for an hour and a half, but you can review the different modalities here. Of course, driving pressure is less than 14 in all cases, and this is taken from one study. Now we're aiming actually the idea is the lower the driving pressure, the better the outcome. I aim for lower than 12 centimeter at least if possible. Tidal volume can actually be a bit higher than 6 also in only cases of lower recruitability, in cases with PF more than 150, in patients with focal lung morphology. You can accept between 6 and 8, otherwise it has to be 6 or less. PEEP, I would actually use higher PEEP in higher recruitability, in PF ratio of less than 150, in non-focal ARDS, and in hyperinflammatory ARDS, but better guided by different modality like the EIT or measuring mechanics. And proning would be more beneficial in recruitability, in high recruitability patients, in patients with PF ratio less than 150, and in patients with focal lung morphology. Let's end with this poll. Do you believe ARDS subphenotypes should guide ventilation strategies? Yes, focal versus diffuse. Yes, hyperinflammatory versus hypoinflammatory. Maybe in future trials, not practical in real time. And with this, I would end my presentation and giving it over to the organizers.
Thank you very much, Mazen, for this detailed lecture. And we open now this Q&A.